Good morning, everybody. I am so excited to be here. Thank you for joining us on this Monday after Thanksgiving. I hope everyone had a good long weekend. We are here to welcome our speakers to Grand Rounds for their talk, Sexual and Reproductive Healthcare for People with Disabilities. So you'll see Erica Monasterio is a professor emeritus of family healthcare nursing from UCSF, where she spent over 20 years on faculty. She obtained her registered nurse training at San Diego State before moving north to UCLA, where she worked as a labor and delivery nurse. Who knows, maybe was there when some of us were delivered or when some of us were in her training there, and obtained her NP training where she applied working with marginalized youth in her work subsequent in San Francisco.
Where did everybody go out?
Lisa, you're frozen. She probably can't hear that.
Am I back?
You're back.
You're back.
Now you're frozen again.
Oh, am I back?
You're back.
Okay, sorry, Cam, blame the new building. So she also directed the Family Nurse Practitioner program. She sees herself as an educator, advocate, and someone who links social justice with healthcare delivery within the women's health movement. And we also have Robin Wilson-Beattie, a disability and sexual and reproductive health educator. So through her work as a member of the American Sexual Educators Group, Counselors and Therapists, the Women of Color Sexual Health Network, and a member of the San Francisco Sexuality Information Training Program, she addresses the need to disseminate research, disability, and sexuality information. She uses an intersectional identity lens to inspire others to be equitable and inclusive in their own practices. And since she started speaking on this topic in 2008, she's written many articles and contributed to curriculum very broadly. This year, we congratulate her receiving the honor of the Carrie Buck Distinguished Fellow at the Lurie Institute for Disability Policy at Brandeis. So I am just, again, so thrilled to have our speakers here today. And thank you again for logging in after Thanksgiving. Please remember to submit your questions for discussion upon completion or through the Q&A, the chat, text call, stop by my office in Cam, and enjoy your hour.
Good morning, everyone. We're very glad to have the opportunity to be here today and speak with you on this topic, which is really an often very neglected topic in healthcare. We'll convince the thing to advance. There we go. Neither Robin nor I have any disclosures. Robin?
So, hi. So today we're going to develop an inclusive definition of the populations that comprise people with disabilities. We will identify sexual and reproductive health needs, barriers to healthcare, and healthcare disparities for people with disabilities. And we're going to outline the best practices to improve access to and quality of sexual and reproductive health care for people with disabilities.
So in terms of framing this talk, we just want to note that people with disabilities is a very broad category that includes a range of diagnoses, conditions, level of functions, strengths and challenges, and needs for support and facilitation. So when we talk about people with disabilities, we are talking about a very broad group of people who have all very different needs. So we could do a whole class on care for women with spinal cord injuries, or care for women with developmental disabilities, or care for women or people with intellectual disabilities. And this is really trying to cram it all in to a very brief period of time. So what we've chosen to share with you is to make the assumption that in terms of the actual care, as in adjusting contraceptives based on medications that the individual is on, or taking into account the need for menstrual suppression and management for people with spasticity, These kinds of things, we're going to make the assumption that this is your area of expertise and that you can handle that. And we're going to try and share some perspectives that maybe you don't have as much exposure to, particularly Robin's perspective as a woman who can speak personally from her experiences. So, you know, our aim is to be inclusive. Some of the big challenges for providers come around patients who have mobility disabilities. So we'll spend some extra time functioning on that and people who use mobility devices. But we want you to just keep in mind that it's challenging to define the population, that diagnosis or condition does not define level of function. So be careful with your assumptions. What you see is not always, certainly what you see is not the whole person, their whole set of needs, their whole set of strengths, their whole set of challenges. And so individualizing care is essential. And to individualize care, you really do need to be able to get to know your patient.
Okay. So when it comes to disability, you can become, a person can be disabled at any point in the human lifespan. So disability can be present at birth. So you can be born with a condition. Also, a lot of times, you know, people call that developmental disabilities. You can have also childhood developmental conditions. And those are things that come about, we'll see, like with learning disorders or learning disabilities, and or other, you know, conditions that, you know, show up, you know, as a child gets older. You can become disabled related to an injury. For instance, I have a spinal cord injury due to an aneurysm in the spinal cord. So, you know, you can have that. And you can also, disability can come from complications from a long-standing condition. So you can have, you know, a disabling, you can have a condition, but it can change over time and become like another disability. So, and disabilities can be hidden or they can be visible. So some you see, some people have inside. And they can be progressive. They can kind of, you know, be kind of stable, stay in one place, or can come, you know, you can have flares, depending on what the condition is. Also, there are many different ways of looking at disability, called the models of disability. We're talking, most medical professions have been thinking about disability in terms of the medical model, which is disability is a condition or state that has to be treated and work towards curing. And then you have the social model of disability that says what is disabling is the lack of access and the barriers that society puts up, making society inaccessible for people with disabilities. And there are other models too, but those are, that's another discussion. That's also another lecture.
Now okay, so you are all probably aware, but we just really wanted to emphasize how very pervasive and present the issue of disabilities is in our country. Its disability impacts all of us. I have a friend who refers to me as the temporarily able-bodied, because as we age, if nothing else, we will encounter challenges with mobility, etc. So, you know, and all of us are just an illness or an accident away from having a disability. So don't, you know, we're all just in the state we are in at the moment we are in it. So 1 in 4 adults in the United States have some type of disability. And these disabilities impact on function. You can see the percentages, with the largest group being those who have mobility disabilities. And this is probably because it includes many elders. Cognitive disabilities is next, followed by challenges in independent living. So needing to have assistance either in the home or in some kind of other living situation. Hearing disabilities are quite common as well, followed by vision, and then difficulties with self-care, any kind of self-care, and things like basic activities of daily living or ADLs. In terms of impact on health, adults living with disabilities are more likely to have obesity. You can see the with and without disabilities chart there. The blue line is the with disabilities. Adults living with disabilities are more likely to smoke cigarettes. They're more likely to have heart disease and more likely to have diabetes. And again, some of these may be related to the actual disability. Some of the disabilities may be related to these actual conditions. And many of these issues, particularly heart disease and diabetes, also reflect the fact that for many with mobility disabilities, there's the challenge of any kind of active lifestyle. Now, many with mobility disabilities have very active lifestyles, but others are very challenged by being able to really engage in physical activity. And these impact access to care. So 1 in 3 adults with disabilities do not have a primary care provider or a usual source of care. So that issue of getting to know your clients can be very challenging. And for the patients or the clients, getting to know their provider can be challenging as well. 1 in 3 have unmet healthcare needs because of cost. And when you think about cost, you have to think beyond just, oh, well, we have access to insurance. There's all different levels of insurance. There are barriers related to transportation. So sometimes just the cost of getting there. And also anything that is, I have a daughter who has cerebral palsy, so I can certainly speak to this. Anything that is specially designed for people with disabilities is really expensive. And if you can find the same thing that's just a convenience item, it'll be, a quarter as much as if it's something that's actually designed for people with disabilities or marketed that way. And 1 in 4 adults with disabilities do not get annual exams, so don't really have access to routine health care.
So intersectionality, this means that, people don't live single issue lives. And, this is including people with disabilities. You meet one person with a disability, you have met one person with a disability. And a person can also be multiply disabled. It's not, you can, for instance, I'm, somebody with a physical disability, but I also have invisible disabilities of mental health, mental illness, and ADHD. So, you can be, but when we're talking about intersectionality, we're talking about all the other identities in a person's life that impact how they get to navigate society. So these are conditions like your race, your identities, not conditions, but identities like your race, your gender, your sexual orientation, your economic status, your education. All of these things also, I'm thinking too, like your access to language and communication. All of those are identities that impact how you get to navigate the world, how you get treated, how you get, and sometimes how you get access and support to get access to care. And unconscious bias from providers can impact your healthcare access and quality. One topic that that is now come to light and people talk about is, for instance, the rates of Black maternal healthcare outcomes, and how healthcare for Black women the outcomes have been very different than they have been for women who are not Black. And that's one intersection that I can think of, like gender but with disability. And so I am a Black, if you can see, I am a Black woman who is disabled. My experience in going to the doctor is, and how I am treated and how my issues are addressed, are often very different than, say, my husband, who is also disabled. He's autistic and he's white. His experience is different than mine. So that's where we're talking about intersectionality.
So we are hopefully going to share a video with you and then pick this up after. So this is about, I think, 5 or 6 minutes. And please, if you can't hear, let us know.
Okay, so her blood pressure looks like a little low, but it's fine. Can't really do a height and weight right now because I mean, we just can't. So we'll just skip that for today. Looks like me has been using Depo and just here for another refill. Is that right?
I don't know. I'm just her actually. My name's May. It's MEI. And you can weigh me actually, but whatever for today. That's fine.
Okay. Well, she'll be in just a bit. Dr. Ernst will be in to see you. So she'll talk to you about that. Okay.
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 Do you need
so
me
I'm
to
just
move?
gonna. Yeah, I'll do it. It's
No,
okay.
no. I can.
No, it's okay. I'm on it.
Okay.
No problem. All right. So.
Okay.
All right.
Oh, she's here.
Hi. You know, these rooms are so
Oh.
small with a wheelchair in them. Let me just.
I can.
Oh, no, I got it. It's no big deal.
Okay.
Hi, I'm Dr. Ernst. It's so nice to meet you. Hi, you must be me. It's so nice to meet you. How are you doing today?
I'm good.
Good. I'm so glad to meet you.
So
why are you here today?
No, I'm really here because I've been on the Depo shot for so many years, and
The Depo shot works great. I have a lot of patients with disabilities. Has it stopped your periods?
Yes, but I was reading.
So I always find, like, with the patients with disabilities that it helps them stay cleaner down there because they don't have a period once a month. So,
Well, okay.
and the other thing is
True,
for
but-
women with disabilities, well, it stops the seizures. So I think it's a good idea for you to stay on that.
I don't have seizures.
Okay.
But also, like, isn't it bad for your bones? Because I'm not active anymore, so I worry about my bones, and so.
Well, I'm not too worried about that. I think it's a good idea to just stay on it to help control your periods. So, is there anything else you needed today, or do you want me to just put in a refill for that?
One more thing before
Okay.
you go. So pap smear. I'm like super nervous about it, but I think that it's time.
I
I'm
don't
like
think
30.
you need to be nervous because I really don't think you need that. I mean,
I am sexually active.
you are.
It's kind of weird to have her here to.
You know what? It's better if you stay. I might have some questions for you, or you might need to help us move her later. So I would prefer if you just stay for now.
Just put your earphones on, please. Okay. But shouldn't I have it done at some point? Like, because I really don't need cancer. I've got other.
Maybe at some point, but it's really complicated. We could call a lift team to try to get you on the table.
You know what? Minji's great with helping me. Like, I'm pretty strong up here. She can help me move to the table.
You know, women who have a spinal cord injury can get this problem, autonomic dysreflexia, and it makes the pelvic exam kind of dangerous. So I'm not sure we need to do that here today. It was so nice to meet you today, and I'll see you again maybe in a year or two, okay? Nice to meet you.
Thanks.
So we got your height and weight outside of the room. I'm just gonna plug that into your chart real quick.
Love the scale out there. It's a lot. It's really easy to roll on and off. So
Great, yeah. And then according to your chart here, it looks like you want to talk to Dr. Ernst about whether you're due for a pap smear.
Well, I know I'm overdue and I've never had one, so I'm pretty nervous about it today. So if you just let her know I've never had one.
Yeah, absolutely. And we'll do our best to make you comfortable.
Thanks.
Anything else I can do for you?
That's it.
All right. So Dr. Ernst will be in just a little bit. I'll go bring this to her.
Thank you.
We'll get you set up.
Thanks a lot.
Hi there. Hi. I'm Dr. Ernst. It's really nice to meet you. You're Miss Wu?
You can call me May.
Perfect, May.
Yeah, I mean, my main concern is I've been on Depo-Provera for about 10 years now, and I've been reading it's not good for your bones. That's really the first thing I want to ask you about. I love not having my periods, but God, is this good for me?
Yeah, I understand your concern. There is some data that shows that Depo-Provera over the long term can decrease your bone density. And for women who have another risk factor for low bone density, someone who is non-weight bearing, I actually agree with you. I think that there are better options for you for contraception. Before I tell you what else I'm thinking about for contraception, can you just tell me if you're thinking about getting pregnant and what's your timeline for that?
You're the first person who's ever asked me that, and I can tell you, yeah, when I was a kid, I dreamed of being a mom, but
and so I would say just because you have a spinal cord injury doesn't mean that you can't get pregnant. I totally understand that. So the thing that I was thinking might be a good option for you is long-term contraception, like an IUD.
But I just didn't think you could do that for me. I've never heard of someone with a spinal cord injury having an IUD.
Yeah, we've done it before.
Possible.
And oftentimes we can do that right here in the office.
Okay.
I think what we'll do today is I'm going to give you some written information about the IUD. And today we'll try to do a pelvic exam. We'll do a pap smear. We'll do some screening for some infections.
Okay.
And we'll see how you tolerate that. Okay. And then if you do okay, we can try to put the IUD in here in the office.
Great.
Yeah. I wanted to ask you before we do the pelvic exam, if you need help or assistance transferring onto the table.
I think I can do it with just a little minimal assist from the medical assistant. I have pretty strong upper arms, or my sister can come help me.
Perfect. Yeah, that sounds great. Since Minji is used to it, we can grab her and have her help. So before we do the pelvic exam, I'm going to have you empty your bladder. I will go get Minji, and she can help you move over and transfer onto the table. Okay, and then.
Oops. So that was our talk. But we will now go back and kind of re-emphasize some of the issues and perspectives that were shared. I hope as you watch that you could both see things that you might do, things that you hope you don't ever do again, and approaches you might try in the future in terms of providing care. Robin?
So, like as we saw, as Erica mentioned in the film, so some of the family planning challenges for people with disabilities are there's inaccessible healthcare facilities and equipment. For instance, like not being able to be weighed because there aren't scales for people to that can weigh someone in their wheelchair. Or, there are also, accessible exam tables that can also take a weight, but, not a lot of offices will have those. So also stereotypes and discrimination, as you saw in the film, like, oh, wow, you're disabled and you have sex, that sort of thing. Just automatically assuming that someone's disability precludes them from being sexual or being interested in being sexual or interested in being a parent. The whole programmatic, inaccessibility, transportation barriers to accessing facilities. They're having transportation that can transport someone that is, say, in a power chair or utilizing a wheelchair. That kind of transportation is not exactly, there's not a lot of it. So for someone to buy it, those vehicles are very expensive. And, there's also, not, finding an accessible taxi or, either like an Uber or whatever, those are few and far between. Limited coverage of healthcare. You also have providers who don't have disability related training or sensitivity, and who also fail to recognize people as people with sexual and reproductive health care needs. And there are some other challenges there are some problematic interactions between hormonal methods of contraception and some disability related medications, but also not all contraceptives can work well with disabled bodies. For instance, like we were talking about bone density and, not being able to bear weight. So, certain birth control like Depo-Provera can, lead to some bone loss. And so that's, dangerous for someone with those conditions. Also difficulties using barrier methods due to limitations in manual dexterity. Like how are you gonna putting on a condom when, you don't have dexterity or you don't have hands, or loss of sensation, contractures, or spasticity. So there are a lot of other different issues. There are a lot of different difficulties depending on a disability that can hinder that.
I would just add, if you see the citations here at the bottom, you see one from 2000 and one from 2023. And the most striking thing about doing a lit review here for me was that this didn't change. In the 23 years between 2000 and 2023, the same barriers were still encountered by people seeking family planning or reproductive and sexual health care who have disabilities. So we have a lot of work to do, and I'm really glad you all are here today to think about that work.
And
Sorry, go ahead.
Oh, okay. Some other barriers to healthcare access. Okay, you have the limited availability and training of providers, where you have 81% of medical students have no training in disability care. 75% of medical residences, they have no experience in disability care. And 44% of OBGYN clinics report being unable to provide for people with mobility disabilities. And 41% of physicians feel confident in their ability to provide for patients with disabilities.
There has been some progress on this front. There's a national consensus on disability competencies for healthcare education. And there's Haverkamp et al. Published in 2021 these competencies, as well as their process, which was an iterative process that included individuals living with disabilities, families of people with disabilities, advocates, healthcare providers, students, and a wide range of healthcare providers. So this slide, which has tons of information on it, isn't here for you to read it, but for you to know that this does exist. And those of you, many of whom are teaching, can take a look at this and see what are we including in our educational plan? How are we training our students? And how are we reinforcing these messages in the clinical environment when we have students, residents, fellows, etc.
So some of the sexual and reproductive health disparities among women with disabilities, we have unmet needs for contraception, preconception, and pregnancy counseling. Lower utilization of reproductive health care, higher rates of pregnancy complications, leading to, needing to have cesarean delivery, then there's preterm birth. As somebody with a spinal cord injury who acquired the spinal cord injury while I was pregnant, that was very much a complication, and having to have, a C-section under general anesthesia, not being able to have an epidural, and also, having to deliver the baby 5 weeks early, due to developing preeclampsia and all of the other things. So, with adverse birth outcomes. You have higher amongst the disabled population. We have higher rates of physical abuse and sexual assault as compared to people without disabilities. The rates are several times higher. You have higher rates of sexually transmitted infections, lower rates of cervical and breast cancer screenings, less likely to receive pelvic exams at regular intervals. A lot of it, being where providers will be like, oh, we're unable to do a pelvic, or trying to do a pelvic exam in your wheelchair, which is not ideal. There are higher rates of female sterilization, hysterectomy, that also can tie into the fact that when it comes to disability, people sometimes not having that autonomy over their reproductive health rights. If you are under guardianship or any kind of guardianship, that's because the law Buck v. Bell, that ruling has not been challenged and is still upholding, but basically that was a ruling in the 30s that said that if you were in any kind of institutionalized setting, be it or like guardianship, or then the guardians or the conservator or whatever has the right to decide to sterilize you. The thing that, for instance, Britney Spears was under conservatorship. Britney Spears is a singer, and it's kind of famous, and she had mental illness and she was under a conservatorship. She was forced to have an IUD, and she didn't want that IUD because she wanted to be pregnant, but her guardians decided that they didn't want that for her. So, also disabled people, higher rates of mortality from breast cancer.
Robin?
So sorry, Erica, I was like going, next slide. All right, so now we're talking about that. But another thing that we are going to talk about is communication. So sometimes, when we're providers are wanting to talk, one of their barriers they're thinking about is communication. So some of the principles, you need to focus on the abilities and not the disability. So talk respectfully, do not shout, do not infantilize, and do explain what is happening, and do take time. You need to greet the person first before addressing the accompanying relative or support person. Invite your new patients to bring any existing personal health records. And paid support staff, that come with a patient, they may be unaware of vital elements in a person's medical history. So encourage them to make and keep notes and to bring those for subsequent consultations.
When you're taking a history, you need to, of course, consider verbal capacity. So you always want to start, your client knows themselves, their needs, their challenges, their barriers best. So start by asking them how they communicate best. Then you can assess their verbal capacity. There may be an imbalance between receptive and expressive language skills, but don't assume that because of limitations in expressive language skills, there are equal limitations in receptive language skills. In other words, the individual may understand absolutely what you're talking about, but may not be able to respond in a way that is understandable to you, or that you would usually expect a response. On the other hand, They may give clear answers even when they don't really understand the question. So if there was ever a place where teach back is appropriate, working with people with disabilities, especially in assessing their verbal capacity before taking a history, is a place where you really want to utilize those skills to make sure that what you're saying is being understood in the way you're hoping it's understood by your client, and that your client can let you know what their understanding is. You will have many patients who may have limited or absent verbal skills. And you should always start by assuming competence and make sure, again, that you establish contact with the person first, and then ask them if he or she will allow the accompanying person to interpret. And I just want to throw in, this weekend, my daughter proposed a movie night, and we watched a movie on, I think it was on Disney Plus, called In My Mind, which is a really beautiful story about a 6th grader with cerebral palsy who is minimally verbal. And if you have the time, it's a great way to walk in somebody else's shoes for a minute, or roll in somebody else's chair for a minute. And also the family dynamics as a parent of a now adult child with disabilities. It's a very accurate depiction of what life feels like and looks like. And then, of course, you want to get as much of the history from your patient as possible. And with their permission, you can ask the accompanying person to complete it, or often that means somebody going out, gathering information and communicating with you after the visit about the medical history.
So, when it comes to confidentiality and the communication, so you need to, a provider needs to make clear that if the patient wants the accompanying person that came with them to the appointment to leave at any moment during the visit consultation, they can do that. And so make that clear. For people who are nonverbal, find other ways to communicate. You can, observe like body language, such as gestures and facial expressions. Utilize sign language. Use pictorial materials, so pictures to point out, for like body parts, or to help explain concepts, but basically using pictures to kind of get that point to illustrate and to communicate, allowing someone to select or to point. Or also, there are electronic devices that allow for communication. There are electronic voice communicators that people have that allow them to communicate and allow them to select or to type or to select phrases in order to communicate with people. And so you establish if a patient normally uses those communication devices or a system. And if the patient does not use a communication system, then, ask the accompanying person, how do they know what it is that the patient wants? And so, get those answers.
So I want to talk a minute about competency and decision making, because I know as a healthcare provider, this is a big issue for us. There is some guidance, and there's actually a very good article in Up to Date from 2021 on capacity assessment. The provider's role is to really, when you're talking about decision making, is to present the relevant facts for a decision, to assess the patient's understanding of those facts, to ask for the person's choice, to assess their appreciation and reasoning about that choice, and reassess the choice, paying attention to the logical consistency. So is their choice based on their reasoning that they provided, or does their choice contradict the reasoning that they provided? And they've done a very nice job. This is just a chart that was adapted from that article, with some guidance around how to ask these questions. Can you tell me your understanding of what I just said about whatever helps to define understanding. Based on what we just discussed, what would you choose? And that's expressing a choice. The appreciation, can you tell me what you see as your medical problem? Looking at benefit and risk, regardless of what you choose, do you think that it's possible that the medication or whatever we're talking about can benefit or harm you? And do that as two separate questions so that it's not confusing how it might benefit you, how this might harm you. And then reasoning, which is this ability to kind of compare information and infer consequences. So you're looking at comparative reasoning. How is X better than Y? Or consequential reasoning. How could X affect you in your daily life? And these are ways, because we don't, really have clear tools that help us to assess competency. I do want to emphasize, however, that the bar is not real high. In the state of California, a person of any age can make pregnancy-related decisions, including contraceptive choice, any age. And a person 12 or over can consent to STI testing, can consent to HIV testing, et cetera. So, we're not looking for fully developed reasoning, adult thinking when we're talking about the decisions that need to be made in the realm of sexual and reproductive health. So we're going to talk a little bit about facilitating the GYN exam. And this is an image from a lovely movie called Margarita with a Straw that, again, just shows the life of, and in both these movies that I mentioned, the actors are disabled people. It's not somebody acting disabled, they are disabled. Again, it just gives you, it's a coming of age movie that gives a really nice perspective on all challenges and all the normal aspects of being a young person with a disability.
So one of the things we're talking about is preparing for, some of the pre-work that before the appointment. Schedule a longer appointment when we are talking about, treating someone with a disability that's coming in. Select the most accessible exam room and have necessary equipment available, like equipment for transferring, an accessible exam chair table. Also practice with your staff. Practice with the staff, people working at the front desk, doing intake, all of those things. Practice with your staff for asking for a patient's preferences, for providing assistance, and also staff with safe transfer techniques, safe for the person that is doing the transferring and for the person being transferred. And also flag the chart to indicate that this patient requires accommodation, and that can help in for future visits as well.
So we just wanted to show you these tables and talk about requirements. We, as healthcare providers, we are legally obligated to provide accommodation and access. If we don't have a table that can be accessed, so you can see a regular fixed type table is quite high, and is, as a person who helps a grown woman transfer onto that table, it's quite challenging. She does not step, she does not stand, she does not hold herself independently, although she can help, but it's quite a workout. So if you have the option when you're getting new equipment, high-low tables like this make a huge difference. If you don't have that, then you are legally obligated to provide safe transfer. And people need training in safe transfer. It is not intuitive. It is not simple. It is it's a specific set of skills. And you want to not only make sure it's safe, as Robin said, for the people doing the transfer, you don't want to throw out your back. the person being transferred, but also you don't want them ending up half naked with the gown over their head. And, I mean, they should have some privacy and dignity and comfort in the process. So when you think about, what can be traumatic about having a pelvic exam for a person with disabilities, just add this on to the front end. By the time you get on the table, you're already in a sweat and anxious and uncomfortable and worried you're going to fall off the sides and all of those very unpleasant experiences.
And as we're talking about like ADA and thing, access is a legal right. It's not a, oh, nice to have, not out of the goodness of your heart. It's the law. And healthcare providers must have an accessible facility that meets the 2010 ADA standards for accessible design. And here's a link that talks about it. But also in 2021, there were other regulations to also re-emphasize and also kind of been like, yes, this has to be, this is the law. And, you're also opening up yourself up to being sued for your place not being accessible. So access is a legal right.
So in preparing for the pelvic exam, you want to first think, is this for preventative care, or is the data I'm going to collect adding to a diagnosis of a presenting problem? Because when you encounter challenges, you're going to have to prioritize based on how this is going to contribute to decision-making versus being able to find other approaches, perhaps pre-medicate, et cetera, so that it can be a more successful experience. Assure that the patient feels safe and well supported and confident that they're not going to fall. The tables tend to be narrow and it can be scary. And consider using extra padding on the exam table, have lots of pillows, use blankets, anything that can help support your client's body. Assist with transfers as necessary. Adapt your office with an electric table if you can. A high-low table makes it very much easier. And do not perform exams in the wheelchair, including the breast exam, unless that's what the patient prefers and no other option is available. It's like doing an exam with all the patient's clothes on. It's really not state of practice. For transfer assistance, there are several options. You need to educate yourself and the staff that you work with about those options. Some women will need physical assistance. They may want to use a transfer board. They may need a lift. And the transfer strategy for each patient and situation is going to be special and unique. And so you need to find out from them what works for them. In terms of positioning, be aware that there may be impaired balance or weakness. There may be spasticity that can impact how you position an individual or what's going to be comfortable for them, or how you may even be able to do the exam. Watch out for pressure, especially over the sacrum with any prolonged positioning, and contractures. You cannot tell somebody to just relax when they have contractures. Those contractures are often fixed. It's painful to stretch out a limb that has a fixed contracture. So again, you need to ask the client or patient, what works for you? Are you able to stretch this arm or leg out? How can we help you be more comfortable? Some important tips. Have the client empty their bladder first. Even though it takes extra time, it will make the exam more comfortable. And you might want to get a specimen, even if you're not sure if you're going to need it, because once you can get it, get it. Think about alternative positions, and I'll show you a graphic in a minute that can be used to facilitate the exam, and let the patient help you. Use a Peterson rather than a Graves speculum if you need a smaller or narrower speculum. Again, you're going to have to look and see what you need, but do consider that. And you can use, depending on the position, handles up instead of handles down, because not everybody can get down to the edge of the table or feel safe on the edge of the table. Consider a blind pap smear if you cannot insert a speculum, and use urine or vaginal swabs for STI screening and diagnosis rather than cervical specimens. And these are some positioning options. A number of these are for people with hypotonia. So this is for this, so people with spinal cord injuries may be more comfortable in these positions. Here for someone who has hypertonia, this may be a more comfortable position. And you can see there's a variety of approaches. This is a wonderful resource that I think Dakin has made available to you all. I really encourage you to take a look at Table Manners and beyond. Robin?
So we've been talking about, you know, accessible equipment and accessible, you know, tables and things. So there are some clinics and centers where this is being done for on a larger scale, large population. And here I have these are the photo, sorry, of Dr. Anna Tirado, who is in Connecticut. And she works with her practice. She works in a practice where she treats women with disabilities and provides OBGYN care. But she also, you know, has some, you know, specialized equipment, some different kinds of equipment and methods on how to provide, you know, this kind of care that we've been talking about. But there also is another, there's another center. There's a Center for Women with Disabilities, and they provide OBGYN care in Pittsburgh, Pennsylvania. And that is at McGee Hospital in, like I said, in Pittsburgh. And there's a link here, and so you can check it out. But it is, you know, it's a hospital clinic. It's open every single day, not just, you know, one day a week that I've seen for some other programs that treat disabled women in getting OBGYN care. This is an entire clinic devoted to that. And I feel like it is a place where other, you know, physicians and providers should take a look and see what they're doing over there, because it is quite progressive, but also the kind of care that they are able to provide with, you know, techniques and equipment and things. Now, this we had talked earlier about the rates of being higher of sex abuse, sexual abuse, sexual assault amongst people with disabilities. So why is this? Why are the rates that much higher? Well, you have more vulnerability with dependency on others and communication difficulties. When you are dependent on others for your care, for your activities of daily living, and you have issues with communication, that leads you to being more vulnerable to being assaulted. With mild developmental disabilities, sometimes that victimization happens due to the need to fit in. Abuse occurs more frequently with family and caregivers. Only 14% of people are abused by a stranger. And in the American Academy of Pediatrics data, overall incidence is 2 to 10 times higher than for the general population without disabilities. And 68 to 83% of women with developmental disabilities will be sexually assaulted. And so what what contributes to this vulnerability? The factors that are influencing these statistics are less able, disabled people, sometimes are less able to defend themselves, often not alert to potentially dangerous situations, do not know or don't have access to be able to report the abuse. Sometimes people, disabled people can be seeking approval and affection. And, was mentioned with mild, like intellectual disability disorders, they may be more vulnerable due to the desire to fit in with peers. May be exposed to a large number of caregivers for intimate care. You don't always have, when it comes to like home health care or it comes to healthcare workers, sometimes it's a revolving door of people. You don't always, not everyone has the ability or the privilege of having the same caregiver over and over. Sometimes, with the nature of this work, you have a lot of people that come in and come out and doing this work. And also disabled people are taught to be compliant to authority. Like you must listen, you must adhere to what other people are telling you what to do. That whole system of like hierarchy of like authority over. So, and you're taught to be compliant to that.
So there's also the aspect of family attitudes. So I'll just read this to you. Here's a young woman who's a wheelchair user saying, "Mom, I would like to begin my sexual life somehow. Can we discuss this?" And mom says, is this your biggest problem now? You really don't have enough issues? You're only 28. You still have plenty of time. So make sure you're talking to your patient or client, not to their parent, family, caregiver. Because attitudes of family often are to continue to see their child as a child, not as an adult. And then just a note about, about social and communicative impairments. These impairments, and so this is very salient to many people on the autism spectrum. These impairments can impact on the development of friendships and romantic relationships. They may diminish opportunities to learn about sexuality from their peers. They influence your judgment to apply sexuality in a socially acceptable way or in interpreting the sexual intentions of others. They can result in literal or incorrect interpretations of information relating to sexuality. And information about sexuality and sexual codes might not be clear to people on the autism spectrum. So again, it's a spectrum. You have people at every part of that spectrum.
And I know we're getting close to the end, but okay, there are some relationship challenges, for people with developmental disabilities because, negotiating relationships is a learned skill, which it is for every human being. But people with developmental disabilities, they have fewer opportunities to practice that through friendships. They have fewer social outlets and higher levels of adult supervision. And they desire a romantic relationship, but they don't have these models among their peers. And sexual decision making requires some abstract thinking skills. And a lot of times, people with intellectual disabilities, they may not develop that abstract thinking.
So one of the things that we want to do as providers and reinforce in parenting is to teach boundaries and consent, which is not just the right to say no, but also the right to say yes. You want to teach people the right to refuse because, again, there's this training in compliance. Do what the doctor, physical therapist, occupational therapist, social worker, etc. says. And remember that context is everything. How do these messages fit into the individual's actual life? So talking about their social situations as examples rather than bringing examples from outside. And remember that this is not all about no. adults and youth with disabilities desire and seek relationships, including romantic relationships.
And to leave y'all, though, is a word about pleasure. Access to pleasure is also a real accessibility issue. And full inclusion means access to pleasure, and it means having a reasonable chance for relationships and that autonomy to have, make decisions about your sexual and reproductive health care as it relates to it.
So these are some resources that we thought you might be interested in. I think Dekina is going to make available the slides as a PDF. I am sorry about questions. As much as we trimmed this down, we didn't get to them. I know for my part, if Deki wants to put a question list together, I can send her back. Robin and I can work on it if Robin has the time. Send it back to her and send it out to the group. But thank you so much for your time and interest today.
Thank you so much. And let's see if you can see me now. For all of those planning to work in CAM today, beware the internet. Thank you so much for that wonderful talk. We love the resources, right? OBGYNs, we like to do things. We tend to be biased towards action. And so there were so many usable tips and tricks. So very much appreciated. And that was one of the questions that came up, as you mentioned, that the number of primary care providers for people with different abilities is lower. And in general, we're seeing that people are having access across the nation. I was curious about what other resources we can direct patients to educate themselves that's sort of outside of the traditional medical system. Were there some examples like that in your resource page?
So there are simple language examples, pictorial representations and resources where you can look for things like social stories, which are helpful for people with intellectual disabilities. Again, the range is so broad that what people might want to access is going to be varied. There is the book that's there by Miriam Kaufman. I can't remember the name of it right now, Sex and Disability, something like that. It's a wonderful book. It is written for people with disabilities. It is very explicit, very concrete in the information, gives lots of background. And I would highly recommend that for your clients who are interested and who are readers or who have some way of, taking the written word into voice.
Got it.
I
And
can also forward some resources that are for disabled, that were created by disabled people for disabled people in going to the doctor and going to get reproductive and sexual health care. There are some things that've come out in the last couple of years. It just came out. But like the National Center for Disability has put out a pamphlet. Also like Access Living in Chicago also has put out some resources about sexual and reproductive health care for people with disabilities in seeking that kind of health care.
Fantastic. And then for those who are still on, we had one more question about the pelvic examination. I know there's been lots of discussion about the utility of the pelvic examination and what does it reveal, and the ability, as you had mentioned, to screen for STIs with urine samples, doing other swabs, testing for HPV. So just sort of that question as to whether there's a conversation going on to sort of list what are really the pieces of the examination that are sort of not necessary, but kind of along the evolution of practice as we find alternate methods to examine women besides the traditional pelvic exam.
I think we really are finding that, especially with the variety of imaging techniques, with HPV vaccine, we have generations coming up who have been vaccinated since, the day after birth. There are other ways to screen. I think that the efficacy of the pelvic exam, I think we'll see a shift like we've seen with clinical breast exams. And more and more, this is something that we did when we didn't have other tools. And particularly for people who have mobility disabilities, spasticity, problems with transfers and positioning, it's something that we can hopefully put in the rear view mirror and use other modalities. Right now, the limitations are that, of course, it's less expensive to do a pelvic exam than to do the imaging, et cetera, that might need to be done to get a full picture. But absolutely a conversation that is ongoing and that, hopefully all of us can contribute to.
Absolutely. And then one last question, given that you both are educators and you've seen generations of trainees kind of come through with each and every year, how has perspectives of the future healthcare workers changed over the time? I know you had mentioned that, I think you had said about no change in like some policy regarding disabilities in 2 decades, but what do you see in the future given your exposure to the future healthcare providers?
So let me answer that and then let Robin have the last word, because hers is the most meaningful word, I think. As somebody working with students, trainees, fellows, residents, etc., what you can tell when they've had exposure to disability content, or when they have a person with disability in their life, or when they are dealing with a disability themselves, because their sensitivity, their wealth of information, their perspectives, and their desires to know more are much more marked. So those are the ones that'll say, oh, you have a patient with a disability? I'd love to see them, instead of running and hiding in the bathroom when, that person comes in the door. I think that, the more we teach people and the more exposure, again, full inclusion in schools, that children have more exposure to their peers with disabilities, all of this contributes to an openness of mind. And that's where we need to start.
I am also seeing as I've been doing now this work for about a little over a decade, and so but what I have noticed is and I talk a lot with like first, second year residents, med students. I'm noticing that they have more language and more exposure to disability. That also, like as Erica was saying, we're talking about inclusion in school. So, going to school, having disabled, people in, at their school, but, kind of, kind of like peers, but also I'm noticing a difference. Doctors identifying being disabled themselves as having disabilities and being able to be out and talk about those disabilities. I have seen actually, med students with disabilities, they've formed groups and in schools and colleges also, but disabled doctors and disabled providers. So but I'm also seeing a lot more willingness and openness in, addressing these things and in talking about disability. So I have a lot of hope as I see, each, seeing, each classes and generation of students coming in. It's actually it's very hopeful. And but also seeing this willingness and wanting to make sure that people with disabilities can be treated and get correct and proper treatment.
Absolutely. I think that's wonderful. And ending on a hopeful note is a wonderful thing. So glad when we can do that in these times. So thank you so much for joining us, talking about a topic that is so true to our mission and vision, and advocating for people and inclusivity is central to everything we do. So we are thrilled to welcome you into our community. Thank you to everybody who stayed into their bio break. You have about 4 minutes until M&M break. So short bio breaks, plug from the Euroguide. Thank you again. And then we will collect any questions and send along from Day Keen. So please don't be shy about emailing or texting so that we can get them their list. Thank you guys so much. I hope you have a wonderful rest of your day.
Thank you so much. Bye-bye.
Thank you. Bye.
Bye.